Hey, my menopausal students. Welcome back to Menopause University, where you receive the menopause education you and all women deserve. I'm Menopause Taylor, the gynecologist who is determined to ensure that you get it and that you understand everything. The great thing about this YouTube channel is that I don't have a product or an angle to push. I'm all about the education. I just tell you the whole truth and the whole story. What you do with the information is entirely up to you. We are in the midst of a big unit on epithelial ovarian cancer. This is video number 436. It's the 24th video in the unit. Last week, I presented the options that have been proposed and tried for purposes of screening. The idea behind screening is to designate which women have a suspicious ovarian swelling that could be epithelial ovarian cancer. This is critical because epithelial ovarian cancer does not produce any symptoms early enough to diagnose it at an early stage. As a result, it is an extremely fatal disease, but that's not all. There are all sorts of ovarian swellings, some of which are entirely normal or very unlikely to be malignant. What we need in a screening test is some means of separating the ones that are likely to be malignant from the ones that are not. Screening is desirable because there is nothing short of invasive surgery for actually confirming or refuting an epithelial ovarian cancer diagnosis. This is very unlike other diseases for which we have screening tests followed by non-invasive tests to confirm or refute a diagnosis of cancer. With epithelial ovarian cancer, we have a situation in which women with benign ovarian swellings are subjected to a massive invasive surgical procedure, only to discover afterward that they did not have a malignant ovarian swelling. Last week, you learned that there are 3 potential options proposed as screening tests for epithelial ovarian cancer: pelvic exam, transvaginal ultrasound, and a blood test called CA-125. But you discovered that none of them is worthy for use as a screening test. This is due to a number of problems with all of them, including subjectivity, skill level, different kinds of ovarian swellings, low specificity for epithelial ovarian cancer, low sensitivity for epithelial ovarian cancer, and poor positive predictive value for epithelial ovarian cancer. So now we are left with an uncommon but extremely deadly cancer for which we have no screening test. A screening test assesses all women for the cancer, but because these potential screening tests are unworthy for assessing all women, the overall population of women undergoes no assessment whatsoever for epithelial ovarian cancer. And this leads us to our topic for today, which is risk assessment for epithelial ovarian cancer. This shifts the focus from all women to just all women with ovarian swellings. So it's no longer a screening test. Instead, it's an assessment of risk for particular ovarian swellings. In other words, if we can't screen all women for epithelial ovarian cancer, how do we assess the ones with ovarian swellings who need heightened surveillance because they might actually have the cancer? Or said another way, how can we assess the ovarian swelling before surgery to detect the ones that are malignant? The goal is to avoid operating on all women with an ovarian swelling, some of which will be benign, just to get a diagnosis. How do we designate just those that warrant surgery? The big key here is that we are still addressing how to merely get an accurate diagnosis. And we want to find some way short of major surgery for doing so. Now, in my book, both the first and the second editions, I do not go into this deeper subject on risk assessment. I merely point out that there are no screening tests for epithelial ovarian cancer. So, keep watching this video. Let me start by reminding you that the ultimate goal of any screening test is to save lives. And the way any screening test saves lives is by detecting the possible presence of a cancer in its early stages, before it becomes life-threatening. No screening test is perfect, and they all err on the side of labeling too many results as abnormal, rather than too few results as abnormal. They prefer to say it's abnormal rather than normal, just in case. In other words, they all create some false alarms. So it's absolutely normal for any screening test to have some things wrong with it. But a worthy screening test offers more things that are right than wrong. Many right things can overcome a wrong, and many rights certainly do not make a wrong. Nor do many rights get outweighed by a wrong. Well, since we don't have any worthy screening tests for epithelial ovarian cancer, we need a risk assessment tool that is mostly right in terms of how it serves its purpose at designating just those ovarian swellings that are malignant. Of the 3 potential screening tests I presented last week, the most promising one was the CA125. It was more worthy than pelvic exam or transvaginal ultrasound, mostly because it's objective rather than subjective. That's what's right about it. However, it is not specific for detecting only epithelial ovarian cancer. And it is not sensitive enough to be elevated in all women with epithelial ovarian cancer. So those 2 things are the things that are wrong with it. And just as your mom taught you long ago, 2 wrongs do not make a right. Well, when the CA125 test proved unworthy because of what is wrong with it, medical professionals had a difficult time accepting that there was simply no way to screen all women for epithelial ovarian cancer. So instead of trying to assess all women, they changed their focus to assessing only those women who have an actual ovarian swelling. This means that the focus shifted from assessing for the possibility of an ovarian swelling to assessing actual ovarian swellings for the possibility of malignancy. In video number 417, you learn that there are many different kinds of ovarian swellings. All told, there are 21 different kinds of ovarian cancers classified by their cell of origin. Here's the chart we made for that in video number 418. But each one of these can have any one of 3 different degrees of malignant potential: benign, borderline, or malignant. Here's the chart we created for that in video number 417. This means that there are 63 different possibilities for any ovarian swelling. But the focus for menopausal women is mostly on just the epithelial ovarian cancers. Here's the chart showing that from video number 419. The cancers of interest to us are the ones in the last column in bold font. So instead of screening all women for all of these cancers, doctors decided to merely assess for which ovarian swellings were likely to be malignant. And that would serve to limit invasive surgical procedures to only those women. As you saw in last week's video, all of the unworthy screening tests result in performing surgeries on many women in order to detect even one epithelial ovarian cancer. So risk assessment tools were developed for purposes of limiting surgeries to those who actually have malignant cancer. So let's see what's available in the realm of risk assessment tools for epithelial ovarian cancer. You know, some things about my profession astound me. You've seen that I am brutally honest about how quirky some things are in medicine. And I know people find it difficult to accept things that upset them, and they don't like it when we haven't all the answers. Sometimes they even choose to behave in accordance with fear and illogic rather than facts and logic. And yet, even though we all learned at very young ages that two wrongs do not make a right, it astounds me that medical professionals still attempt to force wrongs into making a right. And as I present these risk assessment tools, you'll see what I mean. I'll start by refreshing your memory with the definition of risk assessment tool. Now, the exact definition can vary depending on the disease for which you are utilizing a risk assessment tool. Generally speaking, a risk assessment tool is a means of assessing the risk of a disease by using a formula or equation in order to provide the probability of getting a particular disease within a specified period of time. But the definition of a risk assessment tool changes depending on whether you are using it for the whole population versus a specific individual. Since we already know that there is no way to assess risk of epithelial ovarian cancer for the whole population, the risk assessment tools for this disease focus on the individual woman with an ovarian swelling. And that changes the definition significantly. So, for purposes of epithelial ovarian cancer, a risk assessment tool is a means of highlighting just those ovarian swellings that are likely to be malignant and separating them from those that are not. To begin, you need to know that most risk assessment tools for epithelial ovarian cancer utilize something called biomarkers. Biomarkers is a shortened term for biological markers. Some people use the term tumor marker instead of biomarker. Biomarkers are substances in your blood that change in the presence of a disease. For our study of epithelial ovarian cancer, biomarkers are substances in your blood that change in the presence of epithelial ovarian cancer. And the critical aspect of all biomarkers is that we can measure them objectively. So they all have normal and abnormal lab values with distinct objective ranges for each. Low values are consistent with benign ovarian swellings, while high values are consistent with malignant ovarian swellings. So let's explore the biomarkers that serve as risk assessment tools for epithelial ovarian cancer. I'll present them one by one. Our first risk assessment tool is called the Risk of Ovarian Cancer Algorithm. The acronym is ROCA, ROCA, and I'll use the acronym for our discussion. The ROCA test is very interesting. Instead of just one single CA-125, it's the CA-125 every 3 months. So this is a situation in which you use a non-specific, non-sensitive test over and over again. I don't know about you, but that just doesn't make sense to me. Doing multiple wrongs do not make a right. Doing an unworthy test over and over again does not make it worthy. In any case, the ROMA test calculates the changes in CA-125 over time in order to designate the likelihood of cancer in an ovarian swelling. It compares your results of multiple CA-125 tests over time to that of a database profile. If you have a flat profile in comparison to the database profile, your ovarian swelling is unlikely to be a malignant ovarian cancer. If you have a rising profile in comparison to the database profile, your ovarian swelling is likely to be a malignant ovarian cancer. You purchased the ROMA test online, so obviously it's a commercial product, and it costs about $295. The second risk assessment tool is called the Risk of Malignancy Index. It goes by the acronym RMI, and so will I. The RMI attempts to quantitate the likelihood of malignancy in an ovarian swelling by combining three different things: your menopausal status, your transvaginal ultrasound results, and your CA-125 value. So, it combines two of the unworthy screening options and uses them as if they are worthy. In other words, it tries to force two wrongs to make a right. Ultimately, the most this risk assessment tool can do is help determine whether or not you need a specialist for your surgery. The kind of specialist for ovarian cancer surgery is a gynecologic oncologist. And the cost of the RMI varies by lab. The third risk assessment tool is the OVA1 test, OVA1 test. And this one elucidates one of my pet peeves about acronyms. More often than not, people do not know the words that an acronym represents. And in non-medical literature, it is disturbingly common for the acronym to appear without ever specifying what it means. This is rare in medical literature, and yet that's the case with this acronym. It drives me batty. The OVA1 test consists of 5 different biomarkers that change in the presence of epithelial ovarian cancer. One of the 5 is CA-125, but the other 4 are completely unfamiliar to you. The 5 biomarkers are transthyretin, apolipoprotein A1, beta-2 microglobulin, transferrin, and CA-125. The way it works is that you have your blood drawn for all 5 of these, and then a software algorithm generates a score of probability for epithelial ovarian cancer, taking into account your menopausal status. If you are pre-menopausal, a score of 5 or greater represents a high probability for cancer. If you are post-menopausal, a score of 4.4 or greater represents a high probability for cancer. There are no parameters designated for perimenopausal women, even though perimenopause can last anywhere between 2 and 10 years. The OVA1 test is more sensitive than any of the 3 unworthy potential screening tests we discussed in the last video. This means that an elevation in the OVA1 test is a consistent and reliable consequence of epithelial ovarian cancer. But it is sensitive for a range of ovarian cancers, not just epithelial ovarian cancer. And on the flip side, it is less specific than CA-125 is all by itself. This means that an elevation in OVA1 is not specific for epithelial ovarian cancer. It can be due to some other disease. Still, it detects 70 to 95% of cancers that are missed on pelvic exam or transvaginal ultrasound. Women with a normal OVA1 test are likely to have benign ovarian swellings rather than malignant ones. So the OVA1 test involves some trade-offs. In some ways, it's better than the CA125 test alone. In other ways, it isn't. Oh, and it costs $600. The fourth risk assessment tool is human epididymis protein 4, and the acronym is HE4. This test is more sensitive than CA125 for diagnosing epithelial ovarian cancer in the early stages, and it can diagnose cancers that do not increase your CA125. So the main use of HE4 is in separating benign from malignant ovarian swellings. But it is not approved for the diagnosis of any ovarian cancers. Instead, its primary use is for monitoring progression of the disease after you've already received the diagnosis and undergone treatment. So it serves the wrong purpose entirely. It's right for purposes of indicating recurrence and detecting progression of ovarian cancer. If your value increases by 25% or more, it indicates either recurrence or progression of your ovarian cancer. So here we have a situation in which, instead of having a tool that helps you detect ovarian cancer in the first place, you have one that is merely right for following its progress. And if that's the case, it really isn't a risk assessment tool at all. It's not right for that. It's merely a monitor for the disease progression. So this test is all wrong because it doesn't serve the right purpose. And the HE4 test costs about $300. Our fifth and final risk assessment tool is the risk of malignancy algorithm with the acronym ROMA. ROMA. The ROMA test is a combination of your menopausal status, your CA125 results, and your HE4 results. So it adds one unworthy screening option to unworthy monitoring tool and attempts to make the two together worthy. But two wrongs don't make a right. All it does is determine if you need a gynecologic oncologist for your surgery. Of all the other tests, it is most like the RMI, which combines your menopausal status, your transvaginal ultrasound results, and your CA125. If you're premenopausal, a ROMA score of 13.1% or greater indicates a high risk of your ovarian swelling being malignant. If you're postmenopausal, a ROMA score of 27.7% or greater indicates high risk of your ovarian swelling being malignant. And once again, if you're perimenopausal, there are no parameters for you. The cost of this test ranges between $60 and $540. So what you have as so-called risk assessment tools are merely combinations of the unworthy potential screening tests along with one tool that isn't for screening or diagnosis at all. To me, that constitutes multiple attempts at forcing two or more wrongs to make a right. Like your mother always said, two wrongs do not make a right. Of course, I've condensed all of this into a chart for you. Along the top row, I've listed the 5 risk assessment tools for epithelial ovarian cancer by acronym. And the only reason I'm listing the acronym first is because one of the tools doesn't even have a real name. In the first column, I've listed all the factors that I discussed for these tools. You can see the details and compare them easily in all the multicolored cells. And it's all the stuff I presented in this tutorial already, so I won't rehash it all again here. As usual, the chart is available at menopaustailor.me as well as via the link in the description box. And the chart is your detailed summary. What bothers me about all these efforts to assess ovarian swellings and determine whether they are benign or malignant is that doctors are losing sight of the simplest thing of all. And that is the basic fact that no ovarian swelling during post-menopause is normal. Never. So why not keep it simple in postmenopausal women? In postmenopausal women, every ovarian swelling is cancer until proven otherwise. And because postmenopausal women have non-functional ovaries, all ovarian swellings in all postmenopausal women should be removed. This would solve a lot of problems. Sure, it would entail some surgeries on women who turn out to have benign swellings, but it would not miss any of those who have malignant swellings. I've told you before that in medicine, the pendulum swings a lot from one extreme to the other, and this is an area in which the pendulum has swung way over to the other side recently, the wrong side. I'm old, and when I did my OB-GYN training, the rule was all ovarian swellings in postmenopausal women are cancer until proven otherwise, and they all got removed. But then came managed care and guidelines and efforts to save money. And suddenly, it became common to watch ovarian swellings in postmenopausal women. Watch them for what? Watch them advance to more advanced disease? It just doesn't make sense to watch an ovarian swelling in a postmenopausal woman. A postmenopausal woman's ovaries should never be swollen. And if they are, the swelling is not going to resolve spontaneously. As you learned in video 415 on the life cycle of your ovaries, the only swellings that resolve spontaneously are the ones that form during the normal activities of your ovaries during your reproductive life. But there are no normal activities of your ovaries in your postmenopausal life. So these risk assessment tools may be worthwhile for premenopausal women, but they are worthless for postmenopausal women. And they all leave out perimenopausal women altogether. So the short and not so sweet summary is this. Despite attempts at creating risk assessment tools for epithelial ovarian cancer, none of the available tools is right for purposes of accurately distinguishing benign from malignant ovarian swellings before their surgical removal. And in postmenopausal women, there is no need to do so because for them, all ovarian swellings are cancer until proven otherwise. They all warrant surgical removal with a gynecologic oncologist either on standby or in the operating room. If we add risk assessment to our diagram on the current state of screening for epithelial ovarian cancer, we get this. As you can see, the current state of affairs with regard to screening or assessing for epithelial ovarian cancer is bleak indeed. So that does it for today. Now that you know we have neither a worthy screening test nor the right risk assessment tool for epithelial ovarian cancer, you're ready to learn how we make the actual diagnosis. So that's what we'll tackle next week. And now I'll tell you that 3 rights do make a right. It is right to go to menopaustailor.me to schedule a consultation. In fact, doing so can make everything pertaining to your menopause right from now on. It's also right to subscribe to my newsletter and my channel. And it's right to follow me on Facebook, Instagram, Twitter, and TikTok. So Class is dismissed, and you should come right back in a week. Bye.